Hello, this presentation is on drugs for asthma and COPD, Part 2. So we will be continuing with our discussion of the bronchodilators, the beta-2 anginergic agonists. Their mechanism of action is through the activation of beta-2 receptors in the smooth muscle of the lung. These drugs promote vasodilation, relieving the bronchospasm. Have a limited role in suppressing histamine release in the lung and increasing ciliary motility. They are used in asthma and COPD. Um, they are inhaled short-acting beta agonists, which are taken PRN to abort ongoing attacks for exercise-induced bronchospasms, and they're taken before exercise to prevent an attack. In hospitalized patients undergoing a severe attack, nebulized short-acting beta agonists are the traditional treatment of choice, and there is delivery with an MDI in the outpatient setting. Can be equally effective to the nebulizer treatment. Inhaled long-acting beta agonists are used for long-term control in patients who experience frequent attacks. So these would be patients that have persistent, moderate, and severe asthma. Dosing is on a fixed schedule, not PRN as the short-acting are. They are effective in treating stable COPD patients, and when used to treat asthma, must always be combined with a glucocorticoid. Used alone in asthma is contraindicated. Adverse effects for inhaled preparations include tachycardia, angina, and tremors because they are not cardioselective. And oral preparations would include excessive dosing. You could have angina and dysrhythmias as well as tremors. Uh, Other bronchodilators include the methylxanthines, and this would include theophylline and other methylxanthines such as aminophylline and diphylline. So theophylline produces bronchodilation by relaxing the smooth muscle of the bronchi. It has a narrow therapeutic index of 10 to 20 micrograms per milliliter. There is toxicity related to these theophylline levels. The drug is usually administered by mouth but may be given IV if needed. It's used in asthma and COPD. The oral theophylline is used for maintenance therapy in chronic stable asthma, but is no longer recommended for treatment of COPD. Again, there's the toxicity. With plasma levels below the 20 mics per milliliter, adverse effects are uncommon, but when they reach 20 to 25, you have nausea, vomiting, diarrhea, insomnia, and restlessness. Above 30 mics per milliliter, you could experience severe dysrhythmias such as V-fib and convulsions. And death can result from cardiorespiratory collapse. So for toxicity treatment, you stop the theophylline, administer activated charcoal, give lidocaine for the dysrhythmias, and IV diazepam for seizure control. You have to be careful for interactions with caffeine, which is another stimulant, tobacco, marijuana, cimetidine, and the fluoroquinolone antibiotics. Next, the anticholinergic drugs are looked at, and ipratropium is used, and it improves lung function by blocking the muscarinic receptors in the bronchi, thereby reducing bronchoconstriction. It's administered by inhalation to relieve bronchospasms. Therapeutic effects begin within 30 seconds, so it's very effective reaches 50% of maximum in 3 minutes and persists for about 6 hours. Adverse effects include dry mouth and irritation of the pharynx, glaucoma, and cardiovascular events. The next drug is the tiotropium. It is long-acting inhaled anticholinergic approved for maintenance therapy of bronchospasm associated with COPD. It is not approved for asthma. It relieves the bronchospasm by blocking the muscarinic receptors in the lungs also. Um, it effects begins in about 30 minutes after inhalation, peaks in 3 hours, and persists for 24 hours. And with subsequent doses, bronchodilation continues to improve, reaching a plateau after 8 consecutive doses or 8 days, since it's administered once a day. Adverse effects include dry mouth, and there are minimal anticholinergic effects with this medication. Next is aclindonium. It's the newest long-acting anticholinergic for the management of bronchospasm and COPD. Same mechanism of action. It peaks within 10 minutes of delivery. It is intended for maintenance therapy only and is not for acute symptom relief. It is given by inhalation, usually twice a day. Adverse effects include headaches, nasal pharyngitis, and a cough. Another drug class that is used would be the combination of a glucocorticoid and a long-acting beta agonist. Among the available combinations, there's Advair, Sympacort, and Dulera. They're indicated for long-term maintenance of adults and children. They are not recommended for initial therapy. What drugs are used for exercise-induced asthma? Um, the cause of this is the bronchospasm secondary to the loss of heat and or water from the lung. It starts during or immediately after exercise. It usually peaks in 5 to 10 minutes and resolves in 20 to 30. Normally, you're going to use a short-acting beta agonist or cromolyn administered prophylactically. So you're going to give those before the exercise. So for kids, you want to find out when their PE is, or if they're going to be in a sports, and have that given before they start. And they should still always have their short-acting beta agonist on hand as well. Um, during the exercise. The beta agonist should be inhaled immediately before the exercise, and the cromolyn should be given about 15 minutes before they are to begin their exercise. For COPD, classifications are mild, moderate, severe, and very severe. Um, it is a measure of lung function, and pulmonary function tests are a staple to be done to look at the um, effectiveness of treatment and the severity of disease. So the treatment goals are to reduce the symptoms, improving patients' health and exercise tolerance, and reduce risk and mortality of the progression of the COPD. Patient classifications, you have Group A with few symptoms, low risk. Group B, increased symptoms, still at low risk. Group C, few symptoms, high risk. And Group D, increased symptoms, high risk. The management of stable COPD includes bronchodilators, glucocorticoids, and the phosphodiesterase 4 inhibitors. Management of COPD exacerbations includes short-acting beta agonists, systemic glucocorticoids, antibiotics, and supplemental oxygen to maintain a saturation of 88 to 92%. Now we'll go on to questions. Patient with asthma is prescribed albuterol, Proventil, ProAir, or some of the names, 2 puffs 3 times a day. The nurse should teach the patient to do what? And the answer is C, wait 1 minute between puffs. And that is a big mistake we see with patients all the time. They do their 2 puffs immediately, one right after the other. So basically, they've only gotten 1 puff. Question 2, a patient with asthma is prescribed triamcinolone, asthma court. What should the patient do? B, teach the patient to use a spacer to prevent fungal infection or oral candidiasis. Question 3, which information should the nurse include when teaching a patient about an inhaled glucocorticoid? The answer is C, use a spacer to minimize side effects, especially the oral candidiasis. And 4, which of the following is not a serious adverse effect of long-term oral glucocorticoid therapy? And the answer is C, hypoglycemia, because it would cause hyperglycemia. And that is it for this presentation. Thank you very much.